Looks like we are just missing one or two people, so that's great. That's great. All right. Everybody get their nap in? Okay. First off, are there any questions about what we covered on Monday? Anything? No questions? That was a lot of stuff. You guys learned it already? Can I clarify alpha and beta? I'm not sure what you mean. You have the one PowerPoint that tells you what the alpha 1 and 2 are and the beta 1, 2, and 3. Again, those are all which are considered adrenergic receptors, which means they bind to norepinephrine and epinephrine. So again, the biggest confusion, and I really don't understand how you can confuse that. Cholinergic bind to acetylcholine, and that should be pretty obvious. They both have choline in their names, acetylcholine and cholinergic receptors. And the adrenergics, not beta 3. And again, there's another PowerPoint presentation, Nada, that shows you the 3 that I want you to know. Yeah, it's right on the PowerPoint presentation. So again, alpha 1, beta 2. All right. Okay. Yeah, and then the adrenergic is for the epinephrine and norepinephrine. Yeah. Okay. So here's a little story to start the class off with, something you might find interesting. So most people know what adrenaline is. Adrenaline is, right? Like getting an adrenaline rush. Yeah, okay. So who can tell me? No, I'm going to pick somebody. Christina Vivers, what's the difference between adrenaline and epinephrine? Nothing? Okay. How about Andy? Andy, what's the difference between adrenaline and epinephrine?
Yeah, is that a trick question?
That's a trick question.
So there's really no difference, right?
It's the same thing.
Yeah.
They're
I get a gold star today?
What's that?
Do I get a gold star today?
Yes, you do. You do.
Right.
Okay, so here's what happened. Okay, so the researchers that discovered adrenaline did something you're not supposed to do in science, and they basically patented and copyrighted the name adrenaline. So the rest of the science and medical world said, fine, we're just going to give it another name. So you won't see the word adrenaline in a textbook or a science book or medical book. You'll see epinephrine. So adrenaline we use in common language a lot. Sounds kind of cool, good adrenaline rush. But because it's copyrighted, we just changed the name to epinephrine. Same thing, same thing. So there's your little story for the day. Yeah. And they kind of use the thing, and then Katie's explaining that. So I haven't put up anything yet. So epi means above. Nephron refers to the kidney. Adrenal means add, above, and renal for the kidney. So anyway, that's so unfortunately, so I guess because it would sound kind of weird or for most people, even though you can find it in books. So even though it's epinephrine, when we talk about the receptor, we call them adrenergic receptors for adrenaline. Okay? All right, any questions on anything? All right, so, okay, Jessica says no, and I guess she speaks for the whole class. So you guys know everything. So what I'm going to do right now is try to inspire you in terms of why you need to know everything that we covered yesterday and give it application to the real world. So let me go here. Boom. All right. First things first, can anybody tell me what the range of glucose in your bloodstream should be? Anybody know?
Is it like 80 to 110?
That's pretty good. That's pretty good. If it's an older textbook, you'll see 80 to 120. If you look at a newer textbook, it'll say 70 to 110, like Cristobal just put up there. And again, that is now officially something I can test you on. And this is milligrams per deciliter. Okay. And again, so we would say that the average is 90. And again, this is going to vary, and we're going to cover this in great detail today. All right. Now, I'm going to draw my blood vessel here. Does anybody know why I'm drawing squiggly lines like this for my capillary? Who can tell me what kind of cells a capillary is made up of? Nope, not smooth. It's not muscle. I'll give you a hint. It's epithelium. Anybody remember? Nope. All right. Thank you, Daniel. Very good. Simple squamous. Good job, Christine. So yes, I just kind of drew some flat cells there. So that's my capillary. Okay. Nope, that's right. All right. So if you haven't eaten in, say, 6 hours, we would call that your fasting blood glucose level. And so that would be around 90. Okay, somewhere in that range. It can be 70 to 110, so we're going to use 90. So that, and again, I don't have a whole lot of room. You guys need to know it's milligrams per deciliter. Now, I eat something. I have a nice big plate of pasta, and my glucose levels can increase to, say, 160. That is going to get the little alarms to go off in terms of a negative feedback loop. I got to get that glucose into the cells. Let me draw a cell for you. And it's just a general cell. Doesn't have any particular type right now. I'm going to draw a nucleus for you. There you go. That's my cell. So then my pancreas, which you're going to learn a lot about. I'm going to just draw my pancreas. Again, remember, the pancreas is, well, you don't know that yet, but that's over by your stomach and your small intestine. So I'm just putting them all on the same page here, and it's not to scale. That's an organ. This is a capillary. Okay, now, When my glucose levels get this high, I'm going to have receptors for glucose that will trigger the pancreas to release what? Insulin. Very good, Suresh. All right. And so that insulin will go into my bloodstream. So it's a hormone. And then it will go to my cell. This insulin is going to bind to an enzyme receptor. Who can tell me what that enzyme receptor is? We covered that Monday. What's my enzyme receptor? I thought you guys knew it all because you didn't have any questions. No one? Okay. I hope you guys don't. I'm not going to sound like your mother, but my gosh, or your father. But do not wait for the study the night before the exam. It'll be overwhelming. Thank you, Joshua. RTK, tyrosine kinase. So I'm going to just draw a tyrosine kinase receptor. Okay. And my insulin is going to bind to it. And I'm just going to make a little whatever triangle. Boom. That's going to start the signal transduction process that we talked about on Monday. So there'll be several steps within the cell, but ultimately, what I'm going to produce is a carrier. A carrier. All right, so this is my RTK. All this is testable too. Anybody know what the carrier is called? Okay, that's fine. Now you need to know it's called a GLUT4. So obviously there's a GLUT1, 2, and 3, but those are for specialized tissues. All right. And GLUT simply stands for glucose transporter. Okay? It's a carrier. So that when the glucose gets into the interstitial fluid, and we're going to do an end around here. And this is glucose. Glucose can bind to the carrier and bring it into the cell. So glucose will go into the cell. Dropping my glucose levels back down to 90. Now, the big thing that people mess up is don't get the receptor confused with the carrier. There are two different things. The receptor bound to insulin, communicating to the cell that there is glucose out there, and the cell made the GLUT and put it on the surface so that it could bring the glucose into the cell. And your gee whiz thing is once the glucose is back down to 90, those glucose transporters, the GLUTs, they go away. We take them off the membrane until the next time you eat. The next meal you have, glucose goes up, insulin is released by the pancreas, binds to the RTK, and the cell creates, that was the worst K, sorry, I just saw that. And now I'll make another group of GLUT4s and bring the glucose in. So this happens every single time you eat. Every single time you eat. And so that's one of your nice little negative feedback. And so remember, with negative feedback, we don't want to, once we get back to where we want, between that 70, we want to shut the insulin off because we don't want to go hypoglycemic. That would be bad. Now, application, hopefully this is quite a bit of application for you already. So now you understand every time you eat, you know what's going on in your body. Now, what are the, we had COVID and they said if you have preconditions that was worse. Who can tell me what a couple of the major preconditions that would make COVID worse for you? Heart disease, asthma, and then Natalia got what I wanted to see, diabetes. And so we're going to go in this in greater detail, but I want you to see how everything that we talked about on Monday applies. So we've already talked about receptors. We've already talked about carriers. We mentioned hormones, and now we're going to put this to a little bit more application. So if I have diabetes, and type 1 just means the pancreas isn't producing the insulin. No insulin. If there's no insulin, that cell doesn't know there's glucose out there. It does not make the glucose transporters, and so the glucose cannot get into the cell. Everybody with me so far? So the glucose levels will stay, and they'll keep going up and up and up. And if you're not taking care of yourself and you know you have diabetes, your glucose levels can get ridiculous in terms of the levels. So again, remember 70 to 110 is the range. If you let your diabetes get out of control, it can go up to let's say 900. Yes, that's possible. Now here's the problem. It's 900 in my ECF, my glucose level. In the cell, it's practically zero. It's zero because you've used it to make ATP. So glucose levels in the cell is zero. Out here, it's 900. Which way is water going to go? Come on. Glucose is zero in the cell and 900. Out from where? It's going to go from where to where? Come on, guys. Out of the cell and into the bloodstream. Right? You guys see this, right? I really hope you guys study this weekend, okay? Because everything I've taught you on Monday, you're going to see it in application, all right? So water's going to leave the cell and go back into the bloodstream. Now, this will explain some of the symptoms of diabetes. Who knows what some of the symptoms of diabetes are? Okay, that's free breath. Yeah, that's a classic. I'll explain that later on. That's a little bit farther than I wanted to go. There we go. Thirst. Okay. A lot of there we go. Now we're talking. Yeah. Okay. Okay. So what happened is, again, the water left the cells, went into the bloodstream. Your kidneys got rid of that excess water, and now you're thirsty and you're urinating and all those things. But what the big problem with diabetes is, if it goes unchecked and you're just not taking care of yourself, this water going from one side to the other is what we call osmotic pressure. Osmotic pressure. It's a force. It's a force. All right. And so over a lifetime, that water pressure is going to continue and continue until this poor capillary just can't take it anymore. And so it's gone. Capillary's gone. No capillaries. And that's really, really bad. And that's why you see all these other people throwing things out there. If you don't have capillaries, you can't get blood to your tissues. So if you have a cut, it's not going to heal, or not heal well, because you need blood, you need the glucose and the oxygen for the cells to repair themselves. So ultimately, the cut doesn't heal, and more likely it's going to get infected because you don't have the white blood cells that provide you with the defenses that we're going to learn about later. You don't have anything to fight the bacterium with. So it gets infected, and yes, gangrene. And so there's only one thing the doc can do at this point, and that is what? Amputation. Very good. And that's the sad thing. For those of you that are going to go into the hospitals and you go to the ICU, you're going to see a lot of diabetes patients that have their limbs amputated because there's nothing they can do. It's too gone. And so, and of course, there's other things. First of all, like you said, somebody said, you have no blood flow to those parts, so they are going to die. They're going to get infected, necrosis. Your retinas and your eyeballs will start to die. The cells there, so you go blind. Your nervous system is affected. But folks, my whole point of this lecture is all those horrible things that we just covered here is because of simple things that you learn in this course. All right, osmotic pressure, too much pressure. I lose these blood vessels. Once I lose the blood vessels, I'm going to lose a tissue, and I'm going to lose my foot, my leg, and so on and so forth. Any questions with that? Okay. No questions. Well then, what happens if you have too much insulin? Yeah, and that can be a thing. So if you have too much insulin, then your glucose levels go way too low. All right? Hypoglycemia. And the problem with hypoglycemia and where it can become life-threatening, because again, the insulin is going to keep pulling the glucose into the cells through the GLUT4s until it can drop to like 40 or 50 milligrams, way too low. And we're going to talk more about that later on. But when you get it down to like 50 or 40, looks like Sharish jumped right on there, but your brain is what's going to be affected first. All right. And you should have learned this in AMP1, but who knows what they covered. But your brain needs glucose. The rest of your cells, if they have to make ATP, can use fats, lipids, and amino acids. Your brain cannot use fats or amino acids. It must have glucose. In fact, the brain uses up 50% of that glucose in your bloodstream. So if it goes way too low, your brain is affected. Now, it, 30 or 40 is definitely life-threatening. But if you just like skip a meal, a couple meals, or you went to bed last night, got up, didn't have breakfast, didn't have lunch, now it's late in the evening. What are your symptoms? Your basic symptoms. If you haven't eaten since yesterday, headache, okay, fatigue, migraine, that's pretty hardcore. What are some? Can get dizziness, lightheaded, faint, yep. And of course, there's you get cranky, right? Or as one of my students taught me years ago, you get hangry, all right? You're just not in a good mood, If you haven't eaten so bad and so long that you have blurred vision, no, that's that. I'm just talking about your normal day when you skipped a couple meals, when you get those, you make it the little shakes, little dizziness. Like I said, you're not in a good mood, those types of things. If you get to the point where you have blurred vision, you need to go to hospital. Okay. All right. So this is the kind of stuff that's going to be on your test, folks. You put all the things I've taught you and you put it together to show how everything works. All right. Beautiful. All right. Here we go. And we're off. Okay, so the endocrine is kind of intimidating for a lot of people. I get that. But the key to a lot of this stuff is you break down the words and it will make it a little bit easier. And I'll explain that as we go on, breaking down words. All right, so everybody can see my presentation, right? We're ready to roll. All right. So the endocrine system, as I said, we're going to get you the big picture here, involves all the organs, the glands, tissues that produce a chemical signal and release it into the bloodstream. And when that chemical signal goes in the bloodstream, it automatically gets a name change to what? Come on, folks. What do we call a chemical signal in the bloodstream? All right, thank you, Daniel and Jen. Good. Jennifer, question? Jennifer, did you have a question? Okay, very good. All right, beautiful. Now, like you'll see in a couple of different other systems, the endocrine system includes glands that are dedicated just to the endocrine system. And those are the ones we'll focus on. So the big head honcho is the hypothalamus, and the underling is the pituitary gland. Those are the big two that we'll spend a lot of time on, but today we'll also talk about the thyroid, parathyroid, adrenal glands. And as you can see, there are other organs that play a role. So even your ovaries and your testes are part of the endocrine system because they release the androgens, the testosterone and progesterone, okay, and estrogen. Even the heart releases some chemical signals into the brain, into the blood, as well as the kidneys. So there's lots of different organs that are involved in producing hormones. And again, like we said on Monday, the nervous system is a short-term rapid response thing. The endocrine is the long-term. for most of your activities, keeping your homeostasis, making sure you have the right amount of potassium and sodium and calcium and glucose, blood pressure, all those types of things are part of the endocrine system. All right. So we'll be talking about all these functions. I don't like to read a slide that's boring, so you can read that, but wide array of functions involved, and we're going to cover a lot of them today. Okay, so these are the big ones: the hypothalamus, pituitary, the thyroid, and the adrenal glands. The other ones are minor roles. The pineal gland basically has one job. Anybody know what your pineal gland is responsible for? Okay. Your MP1 teacher didn't tell you that? Didn't teach you that? Okay. I don't know what you're trying to say, Bacola. There you go, melatonin. And that's for what purpose? Okay, that's your sleep, your circadian rhythms. Okay, let's move on. So again, lots of factors involved in making sure that our cells are doing what they're supposed to be doing. So hormones do have a lot of things. I put out a couple of these because I want you to understand. When I say alter membrane permeability, I'm specifically saying a hormone is going to either create channels or take away channels or close channels or create carriers. So when you hear that phrase, alter membrane permeability, you need to be thinking, that means we're going to change the number of channels or carriers on the membrane. Stimulating gene activity, those are your steroids, okay? And we'll talk more about shutting down enzymes, and inducing secretory activity is going to be a big thing today, because a lot of these glands, the hypothalamus will get one gland to produce something, a hormone, which may get another gland to produce another hormone. And you're going to see a lot of that here in just a second. So, isn't that pretty? Don't you just love the pastels, the pleasing effect on your eyes? Yeah, Katie created this one. And why am I making a fuss about the pretty colors? Oh my God. Okay, so yes, the colors are important. All right. So listen to me carefully, everyone. I hope you're taking notes. On the first test, you're going to be asked a question that says, provide an example of a hormone under each of the types of classifications, the categories. And so that goes for the blue and the green boxes. All right. So you'll have a test where you say, a glycoprotein, a good example of this is follicle stimulating hormone, and so on and so forth. Now, some of you've already been introduced to, all right? So under polypeptides, and hopefully everybody knows what a polypeptide is. That's just a long chain of amino acids that's not quite a protein. But we have oxytocin, which we talked about on Monday. That's the one that causes a smooth muscle contraction in the uterus. So you will have the opportunity on the test to determine which one you want to give as an example. So pick the ones that make, let's see, they're the easiest for you to remember, and put it that way. So what have we talked about under polypeptides? What have we talked about so far? Yes, Andy.
Since men don't have uteruses, do they have oxytocin produced in their bodies?
Yes, they do. And we can talk about that later. Yes. To be honest with you, I can't think of a hormone that both males and females that both don't. I don't know of a hormone where both the male and female don't produce it. Okay, even males produce estrogen and progesterone, just in very low levels, very, very low levels. Okay, so it's just the degree, and we'll talk about that a little bit later on, especially for the reproductive physiology. So, like I was saying, a short polypeptide small proteins, we talked about oxytocin a little bit. We certainly have talked about insulin. So those are easy breezy. Over here on glycoproteins, which one of these, and I'm trying to teach you how to study, folks, which one of these would be the easiest to remember? No one? No one? There we go. That's better. Yeah. Thyroid stimulating hormone. What does thyroid stimulating hormone do, Nita? It's another trick question. No one? Come on, guys. Okay, what I wanted to hear you say is thank you, Daniel. It stimulates the thyroid. It's that simple. Thyroid stimulating hormone stimulates the thyroid. Beautiful. Okay. So that's one of your questions. And then over here, we have, these are amino acids. So tyrosine and tryptophan are 2 of the 20 amino acids that are in all the proteins that you eat, your meats and tofu or whatever fish you want. And then your amazing body takes that amino acid and can convert it into what we call our catecholamines, which includes epinephrine, norepinephrine, and dopamine. And we've already talked about these 3 neurotransmitters. We can also take this tyrosine and make our T3 and T4. So that's pretty cool. And then we take the tryptophan and we can make the serotonin and the melatonin. Okay. Any questions? And of course, you can figure out, you can pick whichever one you want to do there. Okay. All right. Shall we break another myth? I love busting myths. Okay. So this is one of those classic myths. So it's Thanksgiving. We just had a giant Thanksgiving meal, dinner, and you're now flopped down on the couch, maybe watching a football game or whatever, and you've always been told it's why.
The turkey.
Yeah, you were told
The tryptophan in the turkey.
The tryptophan in the turkey. That's what you were told. Well, that's just silly, okay? Turkeys aren't doped up on tryptophan. And like I said, it's just one of the 20 amino acids in all your protein sources, all right? So again, you could have had a giant ham or 3 pounds of tofu, if that's your thing. And so you are sleepy because you ate too much. And what part of your autonomic nervous system is now engaged? Come on, guys. What part of the autonomic nervous system Para, because we say it's what? What do we say? Let's rest and digest. Very good. So that's what that is. So it has nothing to do with the turkey and the tryptophan. It's the fact that you ate a ton of food and now your digestive system is hard at work trying to break that all down for you. Okay, let's move on. And here's the thing that you should be excited about. I mean, truly excited about, and that is by the end of this course, you will know every single one of these hormones. Isn't that cool? And what it does. Well, you guys sound pretty thrilled about that. All right. Okay, let's move on then. And some of these are just for your GWIS here. So again, your amino acids, again, the tyrosine and tryptophan, we just take the backbone of that and then we just tweak it. So we take tyrosine and just tweak it to make the epinephrine. We take the tryptophan and just tweak it and we can make melatonin. All right. And we'll talk about your lipids in a little bit here. All right. So again, when we talk about hormones, if they are non-polar, lipid soluble, they will go right through the membrane into a intracellular receptor. If they are polar, they will need a receptor on the membrane. And we already talked about the second messenger and the tyrosine kinase. And we talked a little bit about the gated channels. So see how this piles up? So, and again, I hate to be, get on my lecture mode here, but again, you cannot treat these lectures I'm giving you or the units as, okay, I'm done with that. You can't treat it like it's a history course where, okay, we're done with the 1860s. I can forget that. No, you can't forget anything. All right, because it's going to come back and come back. You're going to see all three of these types of receptors throughout this course. So you absolutely have to have that foundation that we had on Monday to understand what's going on throughout the entire course. Okay, and you've seen something like this. So here's my cyclic AMP messengers that we talked about on Monday, and this is just giving you an example of the actual hormones down here in the orange box that use this cyclic AMP messenger system, right? And this is just the hormones. There are other stimuli that also will use a cyclic AMP second messenger system. So you have these, and so again, this is just a little bit busier than that slide that you presented on Monday. But again, oftentimes you may have two hormones that may be working together at the same time, or you may have a hormone that will inhibit what the other hormone is doing. A little competition, all right? So a lot of diversity in there. And this is the other one. This is that PIP2 or IP3. That means the same thing, PIP2, IP3. And again, you will have to know both of these. I'm going to go back and forth, back and forth. You're going to have both of these on your test, okay? And so I'm not going to go through this, but the whole purpose of this slide is to show you that down here in the orange box, these are the types of hormones that use the IP3 system. Yes, Jennifer?
I do have a question, like for these, would they show up as a short response or an essay question?
Most of these will be, and that's a good question. When I say essay, because I'm old school, you guys, I think, in especially if some of you younger would call them open answered. Does that make sense? So they're not going to be like really long essay questions, nothing like that. I mean, some of these, most of these you'd use bullet statements, boom, 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 boom. All right. So, and we'll talk about that before the first test. So they're not essays like English essay questions. It's like, outline the steps for this process. And you should be doing small, short bullets, okay? Not a lot of wordy stuff. You'll run out of time if it's too wordy. All right? So, all right. And this is just kind of giving you some examples. This is just for you to look at and go, okay. All right. And again, the steroid hormones, they go through the phospholipid bilayer because they're lipid soluble, and then there'll be receptors inside. And again, most of these are going to turn on a gene. And what I mean by turn on a gene is it's going to get that gene to actually make the protein it's responsible for. Okay. Some characteristics, specificity. Some hormones have a very specific target, i.e., thyroid stimulating hormone, that it only stimulates the thyroid. That's it. On the other end of the spectrum, which should be obvious, is epinephrine affects all your cells. Every one of your cells has adrenergic receptors for epinephrine because, again, it's a flight or fight response. And so if I got that big bear in front of me, I want my heart rate to go up. I want my lungs to dilate. I want my pupils to dilate. I want blood going to my muscles. So lots of different responses to the same hormone, epinephrine. All right? And again, how effective is it? It depends on the level of the hormone. So for instance, we'll use this, okay, if you have type 1 diabetes, that means you're not producing insulin. You're not producing insulin. However, there's a type 2 diabetes where you may be producing sufficient amount of insulin, but the receptors on your cells either aren't there or they're not working, they're not binding to insulin. That's what we call affinity. That means affinity is just like the attraction. So there are cases, a couple different diseases, but for diabetes, there are cases where there is insulin out there and there's a receptor out there, but they just aren't hooking up. They're not bonding to each other. And your cells are very dynamic, so if there's not a lot of hormone out there, they'll try to put more receptors out there to try to capture whatever is. If there's too much of the hormone, then they'll bring in the receptors because they don't want to be overstimulated. Okay. And of course, we talked about the same thing with neurotransmitters. Your hormones can be broken down by enzymes. A lot of your hormones that are floating in your body will be just removed by the kidneys and the liver. All right, we're moving right along. So when we talk about, releasing a hormone, there are several different types or pathways to get that gland to release the hormone. Humoral is an old school word for blood. And then we have hormonal and neural, and we're going to go through all these. So humoral stimuli means just that. A particular substance increased or decreased outside of the parameters, and we're going to get a stimulus there. So a good example is your parathyroid hormone. You have these little parathyroid glands in the posterior aspect of your thyroid gland. And so if your calcium levels get too low, the parathyroid glands will release parathyroid hormone, and that will get the bones to release calcium. So that's humoral. Changes directly in the blood. No receptor or external receptor needed. Neurostimuli, specifically, we're talking about the sympathetic nervous system. So when you go into fight or flight mode, you'll have spinal nerve input to the adrenal medulla, and that will release both epinephrine and norepinephrine. That's kind of like an override. Most of the time, our hormonal stimuli is going to be one gland stimulating another gland. So you're going to see this term tropic a lot. Tropic means a hormone stimulates the release of another hormone. All right. So we have a pretty picture here, and you can see we have kind of what we call axes here. You got the hypothalamus and the pituitary, and the glands that the pituitary is responsible for. So here's where you're going to have to start studying. This is the memorization part where you just have to learn it. So I'm just going to give you a couple examples because there's at least 5 or 6 slides that say the same thing. All right. So this is how it works. And you can see we got a negative feedback loop here. All right. So we have our hypothalamus with all kinds of receptors looking for any anomalies. And let's just say, since we've already talked a little tiny bit about it, the T3, T4. All right. So the hypothalamus is going to detect low T3, T4 levels. So the hypothalamus is going to release thyrotropic releasing hormone. Thyrotropic releasing hormone. That hormone is going to activate the anterior pituitary to release the thyroid stimulating hormone. And yes, the thyroid stimulating hormone is going to affect the thyroid gland and get it to produce the T3 and T4. And we're going to go through all these in the next 6 or 7 slides. So you see you have this cascading type of thing, or what we call like an axis, starting at the hypothalamus all the way down to the actual target organ. And these are just a couple examples of the feedback, all right? So we're going to go through you'll get the, and here's, I'll mention this now, and somebody's not listening in, so they'll ask me later, but on your test, yeah, what Katie is just showing you down there. So on your test, you are allowed to abbreviate these things. So you don't have to write out corticotropic releasing hormone. Understood. All right. ACTH is adrenocorticotropic hormone. You can abbreviate that. All right. That'll save you time on the test. And so, yeah. But caveat emptor or caveat canem? Really? All right. Okay. So caveat is a warning, all right? A warning or caution. So caveat emptor is Latin for let the buyer beware, i.e. the used car. And caveat canem, anybody going to guess what a canem is in Latin? Canis? Canine? Yeah. So caveat canem, beware of dog. All right. So the caveat is you should learn what the abbreviations mean. Don't just remember CRH on face value, because a lot of these tell you where it's going or what it's going to do. So you can abbreviate CRH, but you need to know in your head that that stands for corticotropic releasing hormone. Cortico is the key there because it's going to ultimately go to the adrenal cortex. And the same thing here. You can memorize ACTH, but you need to know what it stands for. So adrenocorticotropic hormone, meaning it's going to the adrenal cortex. So that's all I was trying to emphasize there. Okay. Yeah. This is just to say that, this is just don't worry about this slide. This is just saying that under normal circumstances, the parasympathetic is doing all the work to keep you nice and, balanced, but obviously the nervous system can always override that. That's all I was going to say with that one. All right. And again, all this endocrine activity, for the most part, is autonomic. You don't have any control over that. And again, the hypothalamus is by far the biggest player in the endocrine system. So hypothalamus is up here, in this little area, and the pituitary gland is here. And this is all right now AMP1 stuff. Who can tell me what this little stem is called? You can get a gold star for that. No one remembers what that little stem stands. No. What connects the hypothalamus and the pituitary gland? Vanessa is left. Okay. Nope. Good guess. You're off to the side there. It starts with an I.
The infundibulum?
Very good, Diani. The infundibulum. Infundibulum. Beautiful. All right. So, again, we have these pathways here, and this will make more sense in just a little bit. We have several different slides that show you this. All right. So, okay, here we go. We have the hypothalamus, and it releases just a handful of hormones that we call releasing hormones. So there's your first clue. Put a little star. If the hormone ends in RH, it came from the hypothalamus. Okay? Oftentimes it's going to stimulate something, but it can inhibit, but we're not too concerned about the inhibition part. All right? And here is your big study slide. All right? And I'm going to talk this through a little bit. So these are the releasing hormones. Some of these I don't care that you know. Pay attention to that. All right? So I expect you can write this down. So the TRH is really important. The GHRH is really important. The CRH is really important. And the GnRH. Okay. The PRH, that's prolactin. That's all about producing milk. So we're not going to worry about that until we get to the reproductive system. So you can just disregard PRH and PIH. That's prolactin inhibiting hormone to stop you from lactating. All right. So those are not important. And don't worry about the growth hormone inhibiting. We're not too worried about inhibiting stuff right now. All right. So those are the hormones that the hypothalamus releases, and each one of these is responsible for these hormones from the anterior pituitary. And what you're going to do, I think Katie did a quickie for you. If you scroll, you guys are, yeah. Where what you would do is on your test, you would tell me, well, let's go real quick. I'm going to do this real quick drawing. Then we're going to take a 10-minute break because I don't know about you guys, but I'm sitting here with my knee bobbing up and down, going, All right, so hang on, we'll do this real quick. But again, on my tests, you want to be as efficient as possible. All right, so you want to use a lot of abbreviations that are accepted. You want to use quick arrows. All right, so if I say, hey, what's the relationship between the hypothalamus and the anterior pituitary? Katie gave you a quick example, but what you're going to do, why did that go out of focus? Come on. You can go TRH, and you're going to remember what that stands for, thyrotropic releasing hormone. And I don't know why my camera just went out of focus. Hold on. All right. Is that helping? Come on. There we go. Okay. And then, even with your computer keyboard, you can go, and that's going to give me ACTH, adrenocorticotropic hormone, and that is going to give me T3 and T4. But, I'm sorry, God darn, I'm losing my mind here. I guess I really do have to go to the bathroom. That was silly. Okay, the adrenocorticotropic hormone is going to the adrenal cortex, and then we're going to get something like cortisol. All right. And then I got this all kind of screwed up here, so this should have been CRH. I'm confusing my stuff here. Okay, that looks much better. Sorry about that. I hope I didn't just mess up your minds for life. So now we have the thyrotropic releasing hormone that's going to release the thyroid stimulating hormone, and then that's going to give me my T3 and T4. All right. Now, that's how you would do that. You don't put a bunch of words in there. Even though I use the words, you're just going to do this, and I'll be very happy with that. I'll be very happy with that. Okay, and so on and so forth. So abbreviate when it's acceptable, and use arrows or bullet statements. Boom, 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 and that's it. Okay, it's 6:36. Let's take a break so you can take a restroom break. But let's be back at 6:50. 650. 650. Everybody got it?
I don't even know what this is called. Blackboard collaborate after we take a break.
Every time we take a break, I'll make a new session. Yeah.
Okay, thank you.
And quite frankly, that's just a habit. I didn't need to, but it's a habit because when I used to record the sessions, once you quit the session, it makes a recording, so you have to create a new session altogether. Come on, everybody. Okay, sorry about that. That was my bad.
Exactly. Hey, dude, you forgot to say that you were going to start a new session.
It was an old habit because remember when I used to record them, once I stopped the session, you'd have to go to another session to re-record.
No, we were all just hanging out in the old room. We were still there. I got to let you
figured that out. Yeah, all right. Okay.
Okay. Ready?
We got everybody back.
You have my permission. Ready to go.
Okay. All right, we just lost a couple, but those show up. Okay, so folks, the next couple slides say the same thing, so I'm just going to fly right through them. It just gives you different perspectives, artists. So this one's very aesthetic and pleasing to the eye. This one's a little bit harsher. You do not have to know the nuclei in the hypothalamus. Don't worry about that. All you need to know, and this is the second half, so this is part of your big question, is the relationship between the hypothalamus and the pituitary. And once again, you're going to tell me about the releasing hormones from the hypothalamus that get the anterior pituitary to release its hormones. Remember, we don't care about prolactin right now. And the posterior pituitary, if you remember your anatomy from 2401, the anterior pituitary is epithelial, glandular. The posterior pituitary is nervous tissue. So the hormones that come out of the posterior pituitary were actually made in the hypothalamus in these nuclei, transported down to the posterior pituitary and released into the capillary bed. And the two key there hormones are oxytocin, which we've talked about, and ADH, antidiuretic hormone, that we'll talk about. All right. So in this, don't worry about this slide. Again, it's just kind of writing out the name so you can see it. Same thing. So again, a lot of these just say the same thing. Here's one that you probably should study. Again, remember what all these abbreviations mean, and you're good to go. So this would be more like what you'd want to do on your test. So study this, all right? And one more time, we do not care about prolactin at this juncture because, as you see, it's just primarily for lactation purposes. Any questions? Again, there's very little anatomy. I'm sorry, I'm going all over the place. Very little anatomy that you need to know. I do expect you to know a couple areas that are the most active when you look at this. So don't let all this stuff scare you right here, all right? All I want you to know is the pars distalis, the anterior lobe. That's where all those hormones that we just talked about, the TSH, ACTH, and whatnot, okay? And then on this, the pars nervosa. That's it. Okay, I'm not going to ask, nothing else on this is important, all right? And I didn't mention this before, I don't do a lot of histology. You know why I don't do a lot of histology in A&P, which is heretical to some of my faculty? Anybody? Why don't I make you recognize histology? Nobody wants to guess? Stop it, Katie. Yes, Jennifer.
They all look the same and they're all pink, so it's hard to identify.
That's funny, but no. They look the same. Yeah, you have to spend a lot of time looking under a microscope, and that's the whole point. That's the whole point. Andrea, guess when you're going to look through a microscope when you're in your nursing program, your PA program, your PT program, or your dental hygiene program? Guess when the next time you're going to look through your microscope? Never. Exactly. So I don't know why other A&P instructors get all wrapped up about this. None of you will ever look through a microscope again unless you go into some extreme specialization. All right. So thank you, Dhani. That's funny. I like that. Well, I'm serious. My daughter has been a medical doctor, physician for 8 years, and I asked her that. It was like, Stephanie, when's the last time you looked through a microscope? And she's like, in A&P. So 10 years ago, 12 years ago. All right, let's move on. So I'm going to ask you one question on one lab practical thing about, because I just want, and it's just to reemphasize that the anterior lobe is epithelial. It's high density. That word you may have heard, cellularity. There's very little in between the cells. Where the posterior lobe is nervous, and you can see there's a lot of light area. It's not as, whoever said, it's not as pink. All right. So we'll leave it at that. All right, moving on. You can just well, this, like I said, the parts it just tells you the hormones that you need to know. But again, don't get too deep in the weeds with this slide either. All right. I want you to focus on, go back to this one. Beautiful. All right. And so now, some of these are very obvious, but again, I don't like to read slides. So, the thyroid stimulating hormone stimulates the thyroid, okay, to produce T3, T4. The adrenal corticotropic hormone, ACTH, stimulates the adrenal cortex to produce our corticosteroids, which we'll cover, and so on and so forth. You can read just as well as I can, so I'm not going to read you stuff constantly. Again, don't worry about prolactin. And again, all this is just very basic knowledge here, not to be concerned. And again, now this feedback that you were introduced to on Monday will make a lot more sense. Okay, so the adrenal corticotropic hormone is going to stimulate the adrenal cortex, and there are several different key hormones that will be released. The primary one is cortisol. You guys have probably heard of cortisol, and that does all kinds of different things, as you can see down here. All right, and we're going to keep that simple when we actually get to that. So again, keep it simple. This is also something I don't want you to spend too much time on, because we'll be covering this in great depth when we get to the reproductive system. So I'm not going to ask you much of anything about the GnRH or FSH and LH. All right. The simple thing for follicle stimulating means just that, and so they call the eggs and the sperm, or ova and the sperm, follicles. And luteinizing hormone is primarily focused on ovulation, which we'll cover in great detail later. And for men, it gets us to produce the testosterone. But again, we're not going to spend too much time on that. Okay. Growth hormone simply is that. Don't worry about this. You will probably see this sometime in your future, but I'm not going to make a big deal. So you will not see IGF in your tests, insulin-like growth factors. That's a little bit too deep in the weeds. So don't worry about that either. All right. We're moving right along. Again, not going to ask you anything about prolactin at this point. Neurohormones, oxytocin and ADH. They're, again, produced in the nuclei of the hypothalamus, transported down here, and then released into the capillary beds. Oxytocin, we've already talked about, in terms of the contractile cells of the uterus and the mammary glands. And ADH, which you're going to be very familiar with, is called the antidiuretic hormone. And the purpose of that is to get your kidneys to keep the water. When would your kidneys want to keep the water? When would the hypothalamus and pituitary say, kidneys, hold on to that water? Come on. Simple answer. That's it. That's all I wanted to see. Dehydration. Beautiful. You'll get experts on that when we get to the kidneys and the renal system. All right. Beautiful. And we already talked about that. Again, not a big deal. We'll cover that much later. All right. See all those drawings right here? You don't have to worry about that right now, because we will cover this in great detail when we get to the kidneys. So this little illustration here is just for you to go, oh, okay, not sure what the heck all that's all about. But all you have to do is tell me that we get ADH to retain water. The kidneys will do that. And your little gee whiz fact that you probably already know, 90% of your hangover, if you drink too much alcohol, is dehydration, because alcohol inhibits ADH release. So you pee a lot when you're drinking, which you already know. Okay. And looky here, this is just a cute little thing. This is a very abbreviated, but as you can see, it's an example of ADH binding to a G protein link receptor, and there's our friend cyclic AMP. And the cascading region ultimately basically just puts channels for water to pass so it can reabsorb it. Okay, the fun PowerPoint. And guess what I'm going to do? Guess what I'm going to do with this? You guys are catching on. You're really, really sharp. All right. This is going to be a good class. I have a good feeling. All right. Cindy. Good one. Delete it. No. All right. So let's go. This is called my G words. All right. Thank you, Samantha. All right. So glucose. Hopefully we all know glucose. What do you need to tell me in this course? We break glucose down to make ATP, and that process is called glycolysis. Glyco for glucose, lysis means to split. So all you have to do is tell me that glycolysis is the breakdown of glucose into 2-pyruvate and 2-ATP. That's it. That's it. All right. And the pyruvate, you may know this, but that's going to go into the Krebs cycle and electron transport chain and get me more ATP, but we're not there. Okay, and again, this is where I was saying break down a word so it doesn't look so scary. So the next word, gluco, for glucose, duh. Oops. Neo, what's neo mean? New, very good, Natalia. And Genesis? Beginning, production, creation, yes. So gluconeogenesis is when you take other molecules, especially amino acids. You have the ability, your body has the ability to say, all right, I'm going to take an amino acid and I am going to convert it into glucose. All right? Your body doesn't like to do it, but if it's desperate, it will. So like I said, if you're running a marathon and you just run out of glucose, then your body's going to start taking those proteins from your muscles to make glucose. So yeah, usually your marathon runners are pretty thin people. All right? Glycogen, you should already know this from your AMP1 or your 1308, your test, but that's just the storage form of glucose primarily in your liver, but also in your skeletal muscles. If you have plenty of glucose that you're not using, then you're going to take the glucose and make glycogen. If you're running the marathon and you need glucose and you've already used up the glucose that was already in your blood, you're going to go through glycogenolysis, which is the breakdown of glycogen into glucose. All right? And again, remember, lysis always means to split or break. And so glycogen, and I'm going to break it. And the last G word is glucagon. This does the exact opposite of insulin. So that's a hormone that your pancreas produces, and we'll talk more about that in a second. And that's going to get the breakdown of glycogen into glucose to elevate your blood glucose levels. You got to know these, folks. You got to know these G words. And be careful. And, you know, I'm like, God, why can't they be consistent? So why do we have glyco and gluco? Glyco and gluco makes no sense. Okay? But that's what they did. They did that to all of us. All right? But I'm introducing this because several of these next glands involve the G words, including our next gland, the thyroid gland. And again, okay, that's pretty cool, Andrea. I like when you guys share stuff, as long as we don't know what your cousin's name is. But yeah, so he has type 1, so he has a glucagon emergency shot. Yeah, all right. And now if you didn't know that, now you know why. And for the rest of you, yeah. Okay, glucagon is a hormone that's going to get you to break down glucose or glycogen into glucose. Beautiful. Okay, so the thyroid gland, I don't care about the colloid. Yeah, don't even worry about that slide. All right. Okay, and again, because it took me about a year to learn how to say triiodothyronine. So you don't ever have to say that or spell that ever again. So don't worry about that, triiodothyronine. But thyroxine, that's your T4 and T3. And the key there for your test is what does it do? And again, that's definitely involved in metabolism, glycolysis, and also making new glucose, all right, and getting glucose into the cells. All right. And again, this is gee whiz. This probably, you don't worry about that. In fact, there's nothing on this slide I want you to really worry about. Just understand that triiodothyronine, thyroxine, T3, T4, they need to be transported through the circulatory system because they are slightly or the non-polar. And I don't know if I mentioned that or you heard that, but you don't let any non-polar lipid-soluble chemicals circulate freely in your bloodstream. Why don't you want fats circulating by themselves? What are the fats going to do? Somebody. Come on. If I have a bunch of fat in my circulatory system or anywhere in water, okay, block arteries, cause buildup. Okay, these are good. But again, if you mean by blocking arteries and cause buildup, what I want you to do, it's much simpler than that, folks. What happens if you pour some olive oil into a glass of water? Isn't it going to coalesce and be one big blob? Okay, thrombosis. It can be a fat thrombosis. It's not water level. That's right. So all the fats will come together, and then you literally have a big blob of oil circulating. And yes, we could call that a thrombosis to be sure. It could certainly block a small artery. So we keep each little fat molecule separated. It has an escort. Albumin is the escort because otherwise they just all glom together. Okay, good. But again, not a big deal. And you already saw this slide. But this is what you'll be tested on when I ask you about the thyroid hormones. What do they do? Metabolism, glycolysis, gluconeogenesis, glucose. Glucose oxidation is another way of saying breakdown of glucose, all right, for ATP. All right, and it has dual function, so it's also involved in growth and development. All right, not as much as your steroids, testosterone, estrogen, progesterone, but to some degree. But the metabolism is the big one. And there's just this. You've seen this, so I wonder if it's going to be on a test. He's only shown it 4 times. I wonder. All right. And again, we don't worry about, I'm not going to ask you anything about the histology. So again, this is all about calcium regulation. So again, the thyroid produces calcitonin. All right. If you have too much calcium, which is a rare thing, and so you're going to get rid of the calcium in the kidneys or put it back in the bone if your bones need it. All right. The parathyroid hormone is going to do the exact opposite. If you're low in calcium, it's going to get the calcium from the bone. Okay. Everybody take a deep breath. Everybody with me? You there? Okay. Okay.
Yes.
All right. This is one of the coolest slides ever. Ever. Okay. All right. I hope you're taking notes. What I love about this is how well organized your adrenal glands are. It's pretty cool. All right. So we've already talked a little bit about the adrenal medulla, and that's releasing the epi and the norepi. Norepi. The adrenal cortex is so highly organized. It's amazing. All right. So you got different layers of cells that are responsible for different types of steroids. All right. And so you should really put some time into this amazing slide. So we have the superficial layer, the zona glomerulosa, which produces your mineral corticoids. The central portion is called the zona fasciculata, and it produces your glucocorticoids. And then the last bottom layer is the zona reticularis, which produces your gonadoccorticoids, and we're going to look at examples of each one. And then when you get below there, there's your medulla and your epi and norepi. Beautiful slide. Can't tell you. I hope you love it as much as I do. All right, let's move along. And so this is just a little quick survey. You'll see all these hormones pop up throughout the course. All right, so aldosterone is the most important, and right now, until we get to the kidneys, all you have to do is tell me that aldosterone is going to get the kidneys to reabsorb sodium. Okay, my sodium levels are low. I'm going to produce aldosterone. And let me give you an example. Who wants to take this on? Who wants to be brave and daring for this could-be test question? Who wants to do it? Come on, somebody, anybody? Okay. Oh, Christine, did you volunteer? Christine, are you with me?
Sorry, yes. I can try.
Okay. And everybody pay attention, because these are the kinds of questions. Christine, if my sodium levels are abnormally low, and my patient is being administered sodium, so I know the person is getting sodium via IV, whatever, but the sodium levels are consistently low. What 3 hormones am I going to be looking at to see if this is the problem? Now, the hint is, the first one is aldosterone. But what if the aldosterone levels are low? What's next, Christine? And anybody can jump in and help her except for Katie. So the first question all of you should ask is, where did aldosterone come from? And you would say, okay, the adrenal cortex. And the second question is, what hormone, let me pick on somebody else so everybody gets the fair share. Daniel, if aldosterone comes from, oh no, vasopressins, that's another whole thing. That's the posterior pituitary. So I want you to follow this line of thinking. No. Listen to me. All right. Aldosterone. No. ADH came from the posterior pituitary. So I appreciate you guys throwing something out there. It's better than silence. I like that. Well, that's what a sodium is. It's a, okay, Amy. Yeah, let me answer the question there just so everybody knows. I don't know who answered that. Christina, sodium is considered an electrolyte. All right, electrolyte is just another fancy name to say ions. So sodium, potassium, calcium, those are all electrolytes. So yeah, we checked the electrolyte level, we checked the sodium, it's low. And Amy came up with a good answer, but what you just jumped right up there, Amy. What was in between CRH and aldosterone? Anybody? Come on, folks. Very good, Cindy. Very good. So that's the kind of questions I asked. You're going to say, well, low sodium levels, but they've been stabilized in the hospital, so we're controlling the electrolytes. Sodium is being lost. We check aldosterone, then we check ACTH, and then we check for CRH. That's your answer. Everybody get that? I hope that didn't scare the daylights out of everybody. But that's the kind of... Yes, Andy?
So I didn't get that. Even going through the PowerPoint and studying previously before this lecture, I didn't gather any of that.
Well, that's because it was pretty much just introduced today. So let me go back to here. All right. You see cortisol, or we're using aldosterone, but that's also one as well. And so I could have substituted aldosterone right here as well. But you see the track there?
Yes, sir. I still wouldn't have been able to answer that question.
Well, maybe not today, because you were just introduced to that. So, yeah. So this is all brand new information. That's why we need to study this weekend. But no, I don't expect you to know. But I was just giving you an example. So yeah, if you were to refer to this slide and you had studied it, if I substituted aldosterone instead of cortisol, because again, it's still the adrenal cortex, then it's just, and this is the kind of thing you would actually do in the hospital setting. Doctors, nurses use the old process of elimination when they're trying to assess what's going on here. So whether this is cortisol, aldosterone, or whatever, if that's low, where did that come from? The adrenal cortex, and maybe it's not being stimulated. So I look at the ACTH, that came from the anterior pituitary. Maybe that's not working, so then I go to the CRH. Okay, so there's a pathway here. So again, I just threw this at you today, so don't freak out if it didn't register. You'll have plenty of time to grasp that. I was just kind of giving you an example of the kind of questions I'm going to ask that's going to make you think. So if you studied well, and I could do this for all of them. I could say, what if your T3 and T4 levels are low? It's the same process. You go like, okay, T3 and T4, let me check the anterior pituitary. How's my TSH? Okay, let me check my hypothalamus, the TRH. So those kind of things. All right.
And what type of I guess test would reveal that? Would that be something in a blood draw?
Yeah.
Okay.
They can see. Yeah, they can see, because these are hormones and they would be in your bloodstream. They could check for all of these. Very good. All right. Okay. Like I said, I try to make my classes as practical as possible for the real world. Okay, not just memorizing a bunch of stuff. All right, where were we? Oh, on my favorite slide. Yes, Christine.
So, in like a question, if we're given a target, we just look at the pathway and see what would be affected in the pathway?
Well, yeah, that's the whole point.
Okay.
Yeah, that's the whole point, is for you to be able to follow the pathway, because that's what you do in medicine. You'd sit there, like I said, the process of elimination. It's not this. What's next? Right? Okay, so that was aldosterone. And the cortisol is the one that was on that slide. But again, this is still a corticosteroid. And the big thing here for now, because you'll see this again, is it is basically what we call glucose sparing. Boom. Meaning, remember we talked about this already. So if your glucose levels are low, if you're hypoglycemic, the first thing that's affected is what? Everybody, 1, 2, 3. The brain, all right? And so cortisol is basically a hormone that says, hey, guess what, everybody? The brain needs the glucose. So I'm going to make glucose however I can, and you guys use whatever else you can. And when I mean you guys, the rest of the cells. So the cortisol is released when you are stressed, your brain is overworked, and your glucose levels are low. So it's going to basically get lipolysis. You may have never heard this word, or lipolysis. You could say it either way. You're going to release this so that your other cells will use fats, will use lipids to make ATP. All right? And gluconeogenesis will, and so your cortisol is saying, hey, you rest of your cells, you use fats and amino acids, i.e. lipolysis and glucose, so that the brain can have the glucose it needs. All right? All right, gonatocorticoids. And again, not going to make a big deal right now because this will get a whole full lecture at the end of the semester. All right, so the gonatocorticoids is where we produce the testosterone. So that's where women get most of their testosterone from. And again, and this is just a gee whiz thing. Your body, especially your liver, can take cholesterol, because if you remember anything from your basic chemistry, all these are basically a cholesterol derivative, and we just tweak it. So I can take testosterone and make estrogen. I can take estrogen and make testosterone. I can take testosterone and make progesterone. It's like a Lego set where we just rearrange some of the functional groups, and I can make whatever I need. All right, but again, we'll talk way more about that later on. We've already talked about the pancreas. There won't be any anatomy on the pancreas. I save that for the digestive system, so don't worry about the pancreatic artery or any of these other things. All you need to know for this exam is boom, all right? And we've already talked about both of those, all right? And no, you do not need to know this histology slide, all right? Beautiful. And of course, insulin and glucagon pretty much take opposite roles, all right? When your glucose levels are high, insulin's going to bring it back down by getting the glucose into the cells. If your glucose levels are low, glucagon's going to break down the glycogen and raise your glucose levels, all right? And here's probably a very good study slide. And basically, you're going to say whatever insulin does, glucagon does the opposite, all right? Beautiful. Okay, because I have a graduate degree in exercise physiology, I just can't help myself. So if, you got lots of hormones going on during exercise. So if you're out there and you're running a 10K or whatever you like to do, you will be releasing glucagon to get that glycogen out of the liver and into the bloodstream. Of course, you all should know that you're going to have the epinephrine and norepinephrine. Obviously, they're going to increase your heart rate and all those other things, but it's also going to induce glycogenolysis, just like glucagon is. Cortisol, again, if my glucose levels start to get low, I'm going to try to take those amino acids and make glucose out of them. Growth hormone is going to release the fatty acids from your fat cells. This is the same thing as saying lipid oxidation or the breakdown of lipids. All that means, there's like 6 ways you can say this, but it just means you're taking the lipids, the triglycerides that were stored in your fat cells, your adipocytes, taking them out, putting them into the bloodstream so your cells can use them to make ATP. And then your T4 is going to enhance that glucose metabolism, breaking it down. Now, this is one of my favorite slides. You do not need to be able to recite anything on here. It's favorite because as an exercise physiology guy and whatnot, and a physiologist in general, it's one of those things where, my gosh, if we could get people with diabetes to just exercise and watch their diet, they wouldn't need much of an insulin supplement, all right? Because remember what I just drew in the beginning of the class, how when your glucose levels are high, the pancreas releases insulin. Insulin binds to an RTK, which gets the cells to produce GLUTs so that we can get glucose into the cell. Well, guess what? If you have exercising skeletal muscle, the skeletal muscle does not need insulin. It will automatically make the GLUTs. And that is profound. So if you have diabetes and you have a meal after it's digested, if you go out there and have a nice walk or run, you won't have to worry too much about insulin. But unfortunately, most people are like, nah, no insulin, no RTK. Yeah, but again, that's not, and I hope you were saying what I wanted you to say is I don't need insulin, I don't need RTKs, the skeletal muscle cells, and again, this is for exercising skeletal muscles. If you're just sitting on the couch, no. So as you can see, the only thing I want you to get on this, not to make a big deal out of this slide, is this is a skeletal muscle cell. It sees the actin and myosin doing its thing that you learned in AMP1. It's going to make its own GLUTs. It's not waiting for insulin or RTKs. That's my whole point with that. So yeah, if we could get our patients with diabetes to just exercise more and watch their diet, they'd be in a much better place. Well, you eat your pancakes and then you go for a 10-mile run. All right. So, again, this is kind of one of those slides where it's not highly testable, but again, you see 100 commercials for weight loss and all that stuff and diet pills and diet this and blah, blah, blah. But every one of those supplements, every one of those things, the key is not whatever you're taking. That's kind of like a placebo. What gets you to lose weight, and I'm talking about adipose tissue, is exercise. Because when you exercise, all 4 of these hormones are going to get you to burn fat, or fatty acid oxidation, lipolysis. Like I said, it's got 6 different names. But in gym terms, you would call it fat burning. So these are your 4 fat burning hormones. All right. And of course, you're going to be sweating and losing salts, electrolytes. So while you're exercising, you're going to produce that aldosterone to retain the sodium, and ADH to try to do your best to retain as much water as you can. Okay. This, not a big deal. We all have some stress in our lives, and if it's just what we call the acute stress, the immediate stress, that's all about epinephrine and norepinephrine, all right? If it's chronic stress, day-to-day stressing you out, like taking AMP2 in a 10-week course in the summer, you're going to be in the resistance phase. So your favorite thing is going to be cortisol. So, in simple terms, we call cortisol your stress hormone. Your stress hormone. So, for immediate stress, it's norepi. For long-term stress, it's cortisol. So the only thing I want you to get out of this is cortisol is your chronic stress hormone. Any questions? Okay, so what's next is a chalk talk. Now, we'll be done here very shortly. But since we're not in person, we can't do the lab, the glucose tolerance test. And so I'm going to talk you through it.
I looked for the video and I couldn't find it anywhere. I know.
Yeah, it disappeared. Those things don't stay too long on YouTube. All right. So I'm going to talk the students through it. You are still responsible for that lab, folks. I cannot emphasize that enough.
Are you going to prick your finger?
No, I'm not going to prick my finger.
No.
I'm just going to explain to them what I. Yeah, right. All right. So, what you're going to do, first of all, let me do this. Goodness gracious.
No, what I'm saying is I couldn't find any videos on the repository.
No, they're gone. I don't know. Anyway, okay, class. You guys can see this, right? Yeah. Okay, this is your glucose tolerance test lab. You're going to be responsible for the things I'm going to cover. So listen to me carefully. If we were in class, yes, if you were pregnant, they did this for you. Everybody that was pregnant probably did the glucose tolerance test for what's called gestational diabetes, which is typically normally a temporary thing while you're pregnant because all your hormones are going crazy at that time. All right, so I'm going to give you a little quick interview and a quick overview, and then kind of just draw it out what this is all about. All right, so I post, this is up there, you have access to it. I do want you to read through it, but what I'm going to tell you is what's most important for the test. And then there's some questions, and I do want you, I'm not going to spoon feed you everything, so there are some questions, and I don't know if I emphasized this enough, but on these types of labs that are physiology based, these will be on the lecture exam. I'm pretty sure I mentioned that your lab practicals will only be identifying structures, organs, things of that nature. So the information from this lab handout would be found on your lecture exam. Everybody got that? Can I get a yes? All right. And the way it goes, good, is you see these questions right here on page 2. These are the kind of questions that you will see right on your lecture exam. All right. So I'm going to go through this thing. Then I want you to try to answer these questions to the best of your ability. And then next Monday, every class, I'll ask you, does anybody have any questions? And that's when you ask me about things like this lab handout. All right. Because, again, I don't sound like being a nag, but if every no, they're not, but they're going to be on the test. That's how I test that. So and who do I pick on? Who do I need to pick on? Let's see. You guys are doing pretty good. I'm starting to recognize everybody's name. Samantha. Are you with me, Samantha? Samantha? I see your microphone is up. I'm not hearing anything. Do you have a microphone? All right. Andy.
Sir.
All right. I like that. Reminds me of my military days. All right. Okay, this is a simple thing, Andy. If I ask if there are any questions in the beginning of the class and it's utter silence, it can only mean two things, Andy. What are they?
That we're extremely prepared or that we haven't prepared at all and don't know where to begin to ask a question.
Oh my God. You get another star. That's 2 for you today.
That's what I'm talking about today.
Did everybody hear that? All right. Okay. So on Monday, you should be asking me questions about this lab. So here we go.
Professor.
Yes.
May I suggest that you assume the latter?
Of course, I always do.
Okay, good.
All right, here we go. All right, so I'm going to go to the camera, and I'll talk you through this, because this is the only thing that's very unfortunate about not being in the lab, because this is one that you guys would do individually. So this is the glucose tolerance test, and yes, you typically would get this if you're pregnant, just in case. But it goes like this. We have a test that's going to really stress your system out. And what I mean by that is, on this test, we're going to make you drink pure glucose solution, which means it does not have to be broken down, which means as soon as it enters your digestive system, it's going right into your bloodstream. Yeah, it's kind of gross. All right. Now, this is not normal, folks, because even if you eat your pancakes like Katie wants or your pasta, that's starch, which means that has to be slowly broken down into individual glucose molecules. And that can take hours. So there's no dynamic changes going on. But this is pure glucose. So as soon as you drink it, boom, it's going to go right in the bloodstream. All right. So what would happen if we were in the lab is, first of all, you didn't have breakfast, so you've been fasting, and we will check your blood glucose level. We have a glucose meter, and we can check. And everybody that would be involved in this test should be from where? What range? Come on.
70 to 90.
70 to 110. 70 to 110. 90 is the target. Okay. So, and typically I would, since I don't want the whole, if I had 24 in a class, I wouldn't have 24 people doing that. I would ask for volunteers, because some people can't tolerate that kind of glucose. So I usually take 8 volunteers for this. And again, they fasted, and we got their blood glucose level. And so we're just going to use 90. 56 at the 2-hour mark, that's low. That's pretty low. So most people should start out at 90. All right. Then you're going to chug, and I mean chug, 75 grams of glucose. And that's kind of disgusting, you know. It'd probably be better with vodka, but that would mess up the results. All right. Yeah. Okay, so you're going to drink your glucose solution, and then we're going to take your blood glucose in intervals. Now, they probably, if you're doing this in a hospital for gestational diabetes, they probably just check every 45 minutes or even an hour. But this is more of a science thing, so we're going to check it every 15 minutes so we can just see exactly what happens. So if we were to do this, you drank your 75 grams of glucose, and then at 15 minutes, we'd see that it tracked up. All right? So again, we're talking about And we'll just put this as 200 up here. All right. Again, remember this is milligrams per deciliter. So we started at 90. We check it and it's right there. Maybe 100, 110. Then another 15 minutes, and now we're at the 30 mark. We may say it right here. Right. Then we check it after 45 minutes and we see it's right here. About this time, everything I showed you earlier, all right, now I'm up at whatever, 140. We'll make this 140. I don't know how this is 140. Okay. At this time, the alarm bells go on, and there's my pancreas. All right. You like the sound effects? All right. And it's going to start spitting out the insulin. All right. And so, think that through in your head, what I taught you in the beginning of this lecture, that insulin is going to bind to what? What? What's the insulin going to bind to? Somebody. All right, Bukola. All right, excellent. It's going to bind to the RTK, and that's going to get the cell to make what? GLUT4. Very good, Andrea. Very good. Outstanding, folks. Doing fantastic. So what we'll start seeing is the glucose levels dropping. As the glucose is going into the cell. And we're going to try this every 15 minutes. Okay. RTK, well, and it's one of those weird things. It stands for tyrosine kinase receptor. So they put the R for receptor, TK for tyrosine kinase. I guess RTK just sounds cool to say. I don't know. Okay. Oh, wow, Nikisha. Okay. And so this is what my graph might look like. All right. And here is what is super important. Okay. Pay attention, everybody. If you are healthy, then you don't have a glucose tolerance problem. Your glucose levels shouldn't get up above 180. Okay. All right. And this is just as important. I should be back down to where I started at 2 hours. 2 hours. Those are the two parameters. So if I have a glucose tolerance problem, my graph might look like something like this. That's bad. That's bad. All right, so yeah, exactly. Oh, geez. So yeah, I blew right through 180. I'm way up here, and I'm still high compared to where I started from. All right, and like I said, if the graph looked like that, the doc's going to say, we need to do some more tests because that looks like you just might be diabetic. You might be diabetic. And that's the whole point. So if everything's healthy, it should look more like this. But if you have a glucose tolerance problem, it may be off the charts. Everybody got that? All right. So let's just do one thing. We'll do one thing real quick. I know you haven't had a chance to assimilate all this stuff just yet, but we'll just go right here. Let's see how well we do on one question. Yes. Andrea asked, have I had it? Yes, I've had, in my time teaching at ACC, I've had several students write highly recommended they go see a doctor as soon as possible. I had somebody go up to like 280, which is like off the charts. And I was like, oh gosh, not good. So yeah, it happens. So, okay. So, hold on a sec. Why is that? Close. All right. Samantha. Well, we would know something's wrong if you came into class after fasting and your blood glucose was above 110 or 120. We'd sit there and say, this isn't good already. In fact, I probably wouldn't let you take it. I wouldn't let you take it if your glucose was above 110. Okay, so I just want to go to this one. Put your critical thinking, and you can do the rest of these later. All right, right here. Look at these numbers. Everybody see them on this chart? All right. So Jessica, which one of these people is normal? We got Robert, Emma, and Louise. Which one of these people look perfectly normal? Yes, Derek.
Robert.
Okay. I guess you're backing up Jessica. All right, Robert. All right, good. And which one of these persons has diabetes or maybe has diabetes?
Emma.
Yeah, Emma. She's way off the charts. Very good, folks. Very good, folks. And then poor Emma. Yeah. And then I want you to look at Louise. She's exercising when she does that. And what did we learn today? About exercising skeletal muscle. Is that what we learned?
They release their insulin.
No. Okay, Christine, I wanted everybody to say, hey, if you have exercising skeletal muscle, you don't need to depend on insulin. The skeletal muscle cells are going to make their own GLUT force. As Christine eloquently puts it, no insulin, no RTK, automatic. Yes, the skeletal muscles will automatically make the GLUT force. So I want you to envision, we have Louise, she's on a treadmill, and she's jogging along on the treadmill, and we do this test. So she's drinking that glucose, but as soon as it goes into her bloodstream, those exercising skeletal muscles already have the GLUT force saying, bring it on, bring it on. So her level does not go up, because the other cases where they're resting, they had to wait for the insulin to arrive. Louise has the GLUT force already there, so the glucose goes right into the bloodstream. Does everybody get that? And right into the cells. Okay. All right. Now I want you to take your best college try at the rest of these, and we'll discuss them. And some of these things here, I want you to try to use the G words. All right. These questions right here, what 3 sources of blood glucose, 3 fates of glucose. So answer some of these questions here, and then we'll discuss it. And it looks like Katie already answered one of your questions about there are tissues that don't need insulin, because that would be devastating. So your brain doesn't need insulin because we don't rely on the pancreas to feed the brain. The liver, kidney, blood, they don't need insulin because they have critical things to keep us alive, and we don't want to rely on them. All right. Some of these questions, let me go through this real quick. I'm going to wrap this up here in a little bit, but because this would require you to do a little bit of homework. I think I saw somebody, who mentioned DKA? Andrea did. Okay, so here's what happens, folks. If you have diabetes, all right, or you're starving to death, all right, and you have no other choice but to use lipids for ATP. When you metabolize lipids, they produce what are called ketone bodies, which is a very bizarre name. But it produces, the ketones are three basic molecules. One is acetone. So if somebody mentioned fruity breath, who mentioned fruity breath? Okay, obviously Andrea knows a lot about diabetes. Okay, so the fruity breath thing is because you're producing acetone, and yes, this is the same acetone in your nail polish remover. Okay, but it's much lower levels, but it comes off a little bit fruity when you exhale it from your body. All right. The other ketone bodies are acetoacetic acid, the key word being acid, and beta hydroxybutyric acid, the key word acid. So if you're burning fat as your primary source of ATP production, you're producing a lot of acid, which is not good. So we call that ketoacidosis. So you have too much acid. Remember, where should your pH be in your body? Come on, this is all going to be on your first test. What's a good pH? All right, very good, Cindy. All right. So yeah, so if you're burning primarily fats and you're producing the acetoacetic acid and the beta hydroxybutyric acid, your acid levels are going to go up, your pH is going to go down. That's bad, bad, bad. All right. And so Andrew was talking about DKA, and that just means diabetic ketoacidosis. All right. So that can be a bad thing. That could be a bad thing. All right. And so I just gave you the answer for like 3 of these questions, but, it's kind of cool. And then when we get to the digestive system, then I'll tell you about the other stupid things about, and I don't mean to insult people. I shouldn't have said stupid. What's the word? Misperception? Anyway, keto diets are silly, all right? A keto diet is not a good thing. Misinformation. Thank you, Christine. All right. Keto diets are a hoax, and I'll explain that. Yes, Yanni. And when we get to the digestive system and other things, I'll explain why that's just, don't even get me started. So, oh gosh. Okay. I guess I can do that when Katie is plotting me here, because you'll see this. All right, so we have actually, it's a good thing to talk about now. We'll see if anybody can get this one. All right, everybody, put your thinking caps on. Diabetes mellitus, that is your diabetes that we've been talking about this entire time, okay? And just for your gee-whiz trivia, diabetes mellitus, roughly translated in Greek, diabetes is to flow. Mellitus refers to honey, flowing honey. Guess how they determined whether you had diabetes, oh, I don't know, 200, 300 years ago? Come on. And you can be as gross as you want. No. Okay, Daniel.
Testing
Yeah.
urine?
They would sip your urine.
Testing
Yeah.
urine.
That's what they did 200 years ago. Okay. Yeah, it wasn't easy being a doc back then. Or the lab tech, I should say. Yeah. So diabetes mellitus means flowing honey, which means your urine was sweet. And the only way they could do it back then was to actually taste the urine. And if it was sweet, you have diabetes. All right. So getting back to the question that Katie put to you is there's also called diabetes insipidus. And insipid means to disguise, to be tricky, all right? And so why it got the name diabetes insipidus is because one of the biggest symptoms of diabetes is the constant, frequent urination, polyuria. So they would sit there and go, okay, this person's peeing a lot. Oh, they have to have diabetes. All right. But it's not the typical diabetes. This individual was peeing a lot because this is up for a gold star. Gold star had nothing to do with insulin, had nothing to do with glucose. They were peeing a lot.
Alcohol, drinking?
Okay, that's kind of extreme. Let's say they're not alcoholic.
Did they have too much?
So, and Nikisha gets the star. Joshua gets a silver star. Nikisha gets a gold star. Yes, very good, Nikisha. Yeah, they weren't producing ADH. All right, so they cannot retain water. That's what I want and how I want you guys to think, just like that. So, excellent job. Anybody have any questions? All right, fun class today. Oh, go ahead.
Yes. So when are we going to have the opportunity to go through all these questions?
You have these available to you on Blackboard, and you can either download them or just read them from the Blackboard, but you have access to all these questions right there. And I know, Derek, you missed the first day, but talk to your classmates. They can help you through this. But what I just pulled up is right there in on Blackboard, on your lab handouts.
Yeah, okay. I have a hard copy. I was just wondering about the responses to the questions.
Well, I want you to do a little studying. Almost every question here can be answered with the lecture we had today.
Oh, okay.
The only one that would be tricky, because you don't think about that, so I'll give you this one. Where is it? All right. Number 4, because some people are looking for more than one. Where are the 3 sources of glucose in the bloodstream coming from? Somebody give me one. Come on. Okay, Christine, you got the one answer I didn't think people would get. Yeah. You ate it, food. So what's the other 2? G words. Come on. Remember that G word page?
Nitrogen?
Okay, folks, carbohydrate, that would have been what you ate, all right? Not glycogen. What G words that learned, okay, remember, Cindy,
Glycolysis?
glycolysis is breaking down glucose. Okay, so Jessica gets Cristobal and Jessica together got the second fate or the source, glycogen, and you broke glycogen down. So glycogenolysis would have been the second right answer. And the last G word?
Is it glycocortisol?
No. We want the gluconeogenesis. There we go. Gluconeogenesis. So that's how I want you to answer that as best you can. So the only G word there was it was the food one or from your diet. Or you could make that a G word. How can I make that a G word? Gastronomic, gourmet, gourmand, whatever. Okay. And the other two are glycogenolysis and gluconeogenesis. Okay. All right. I want you guys to put some effort into the rest of these questions. All right. And we'll call it a night. Any questions? Crickets. Okay. All right. I'm hoping to hear lots of questions on Monday.
Thank you.
All right. Okay. All right. Good. All right, guys. Have a good weekend. Enjoy it, but study. It's supposed to be like 100 and freaking whatever. So it's best to stay in and just study anyway. Yeah. Good night, everyone. Be safe. Be good.